Hello and welcome to our attendees here in the U.S. and around the world. Thank you for joining us for today's Nova Biomedical webinar, Breaking News on the Diagnosis and Management of Diabetic Ketoacidosis. Our speaker today is Dr. Guillermo Umpierrez, Professor of Medicine in the Division of Endocrinology at Emory University. Dr. Dennis Begos from Nova's Medical and Scientific Affairs Department will also join us to discuss options for point-of-care diagnostic testing for DKA patients. I'm Rick Rollins, Senior Marketing Manager at Nova, and I'll be the moderator for today's event. You can post questions during the webinar using the Ask a Question tab on your webinar console, and we'll address your questions following the main presentations. A full list of questions and answers will be provided to you soon after the webcast. This webinar has been approved for 1 contact hour of PACE continuing education credit and 1 CERP unit by the American Association of Critical Care Nurses. For participants in one of these organizations, your CE certificate will be emailed to you once you complete a post-webinar survey. A link to this survey will be sent to you just after the webinar concludes. If you fail to receive our email, please be sure to check your junk mail folders in your email system. You can register for future live events on the Nova website and explore our broad library of on-demand content with topics in clinical testing, cell culture, and veterinary diagnostic testing. Be sure to subscribe to receive notice of future Nova educational webinars. You'll also find more information about whole blood critical care testing products on the Nova website. And now to our main presentation. Dr. Umpierrez is a professor of medicine in the Division of Endocrinology at Emory University and president of the American Diabetes Association for Medicine and Science. He has been the recipient of numerous teaching awards for Best Clinical Teacher and Mentor at Emory University and national awards from the American College of Physicians, American Association of Clinical Endocrinologists, the Endocrine Society, the Diabetes Technology Society, and the American Diabetes Association. His research interests include mechanisms for beta cell dysfunction in minority populations, prevention of acute and chronic diabetic complications, and hospital management of patients with diabetes and hyperglycemia. He is the author of more than 400 scientific manuscripts and book chapters and has presented over 300 research abstracts at national and international scientific meetings. In addition, he is the director of the Emory Latino Diabetes Education Program, a nationally accredited Spanish diabetes education program dedicated to providing diabetes education to Latinos. Please welcome Dr. Umpierrez.
Thank you, Rick, for your kind introduction, and more importantly, for the opportunity to discuss with you and the audience on the management of hyperglycemic crisis in adult patients with diabetes. The American Diabetes Association recently, just together with the European Association of Studies of Diabetes, we invited the UK Diabetes, the American College of Endocrinology, and Diabetes Technology Society to join us in updating this important topic. So these are the participants. The American Diabetes Association invited myself to be the chair, and we also invited Dr. Earl Hirsch from Washington, Rosalina McCoy from Maryland, Nuha El Sayed and Robert Gabay, both from Boston and the American Diabetes Association. For the European Association of Studies of Diabetes, we invited Gianpaolo Fadini from Padova and Shivani Misra from London, UK. The ACE invited Dr. Georgia Davis from my university, Emory University. And the UK Diabetes, or the Joint British Diabetes Society for Inpatient Care, invited Dr. Ketan Dattaria, and the Diabetes Technology Society, Dr. Rodolfo Galindo and David Klonoff. So the first statement, or the first consensus statement of the American Diabetes Association for the treatment of hyperglycemic crisis was published in 2009. And it was updated in 2006 and 2009. And this was the last version. So it was 13 years ago. And during the past few years, there have been several publications like this, which state that the need for the new evidence. 13 years is too long And there are so many new changes on the diagnosis and treatment of hyperglycemic crisis. If you go to PubMed and you ask for citations between January of 2009 to September of 2023, you get about 6,000 citations. Most of them are review papers and very few randomized control trials. But we have 5,800 on DKA, 375 for HHS, and hyperglycemic crisis. So it was time to update this. So the American Diabetes Association, instead of going about itself like we did before, we invited all of these societies. The objective is to provide an up-to-date knowledge about the epidemiology, pathophysiology, clinical presentations, and recommendations for diagnosis, treatment, and prevention of hyperglycemic crisis in adult subjects. And we did a systematic examination for publication for 2009. We have a librarian and people helping us. And the target audience is a full spectrum of healthcare professionals, including clinicians, diabetes care team, diabetes educators, other healthcare professionals, stakeholders, and individuals with type 1 or type 2 diabetes. And we summarize our publications that should be coming in diabetes care and diabetology in the next couple of months in different areas. First, we will discuss about epidemiology and outcome, pathogenesis, diagnostic criteria, what is new on diagnostic criteria and the recommended treatment. How do you manage patients after hospital discharge? And we also will discuss today complications of treatment. In today's presentations, I will not discuss special populations or future areas of research because of time. So what is new with epidemiology? This is a global manuscript or global presentation. So we're going to talk not only in the United States, but also Europe and other countries. We're going to talk about cause and mortality. So in the United States and Europe, there has been an increased rate of hyperglycemic emergencies, both in type 1 and type 2 diabetes. Unfortunately, we don't have good population level data on hyperglycemic hyperosmolar syndrome or the combination of DKA HHS. You know, it is known these days that we used to say a patient with DKA has type 1 diabetes. Now we know that about 30% of all patients presented with DKA have type 2 diabetes. And if you look at certain populations, such as African American and Hispanic, who presented with unprovoked, newly diagnosed DKA, have type 2 diabetes. We have a section in this manuscript about ketosis-prone diabetes. And the other thing is that mortality, they used to be 95% before the discovery of insulin, is now less than 1% for DKA. But mortality for HHS, or hyperglycemic hyperosmolar syndrome, is 5 to 10-fold higher. So in a publication from our group in 1,200 patients in 2 hospitals in Atlanta, we used to differentiate DKA and HHS. But we now know that about 30%, shown here to the left in the blue bar, is percentage of patients with DKA. In the gray bar to the right is patient with HHS. And combined the two, it's about 30%. So it's more common to have DKA than HHS, but a lot of patients present with a combination of the two. This is data from England, from the UK. And to the left is the percentage of people presented with DKA from the year 2000 to 2013. And there have been a significant increase. And here's to the right, in patients with type 2 diabetes. So all over the world, DKA admission for type 1 and type 2 has increased. But you should keep in mind that DKA has 40-fold higher in type 1 than in type 2 diabetes. This is data from Italy. And in blue are male patients, and orange are female patients. And you see with time, both in females and men, the rate of DKA has continued to increase. And during the past 2 years, when we lived through the pandemic, we have a significant increase in patients with type 1 and type 2 diabetes. In Europe, there was more common type 2s. In the United States, it's a combination of type 1 and type 2 presented with DKA. And the rate of DKA significantly increased, with 7% of patients with diabetes admitted with DKA during the pandemic. The other thing that we have learned is the innovation of treatment with SGLT2 inhibitors. They are so widely used because it decreased cardiovascular complication, improved glycemic control, and prevent progression of kidney disease. But in patients with type 1 diabetes, unfortunately, we reduce the dose of insulin, and there is an insignificant increase in the rate of diabetic ketoacidosis in type 1 diabetes. The rate of DKA in patients with type 1 diabetes increased 3 to 4-fold in most studies. This is why the FDA and the European agencies have not approved the use of SGLT2 inhibitors in patients with type 1 diabetes. And in patients with type 2 diabetes, the rate of DKA is not very common, but it's increased by 2-fold. So who are at risk when SGLT2s are those who are not eating, those who have ketogenic diet, or those who are going to be NPO for several days? And we have to be careful and be aware that these patients may present with diabetic ketoacidosis. The other thing that we believe that is important in the epidemiology is the significant increase in readmissions. About 20% of patients with DKA are readmitted within the next 4 to 8 weeks. And in this table I'm showing here is that those who have low income, so social determinant of health, unfortunately plays an important role. Maybe they don't get the insulin in the same way. And those who have multiple comorbidities have increased rate of readmissions. The cost in the United States is very interesting. So cost of diabetic ketoacidosis depends on length of stay. And here to the left is charges, and to the right is length of stay for patients with DKA. And what you have is an increasing cost for treatment of diabetic ketoacidosis, despite the fact that the length of stay is decreasing. This is the United States. But if you go to Europe, for example, in the UK, the cost of DKA treatment is about 10-fold lower. Well, in the United States, the cost is about $30,000. In the UK, it's about £3,400 or $3,400. So something needs to change, I guess, when we treat and we talk about complications of diabetes and the high cost in the United States. With respect to mortality, I already mentioned to you that mortality was 95% before the discovery of insulin. But now mortality is less than 1%. In recent data from the CDC, it's about 0.2, 0.4% in patients with type 1 and about 1% in patients with type 2 diabetes. But it depends on comorbidities, what precipitates diabetic ketoacidosis. The mortality of HHAs have decreased significantly and is less than 2% in most series in the United States and in Europe. And unfortunately, much higher mortality rate has been reported in middle income or low income countries that in some areas in Africa can go up to 30, 40%. So access to care and treatment and modalities of treatment needs to be there. And here to the right is the case fatality that I mentioned before is coming down, but unfortunately the hospitalization rate continues to increase all over the world. So the other thing that is important is the risk of death following the admissions of DKA. And I used to be the chair and the director of the diabetes unit in the hospital, and we saw patients coming all over and over again. And what I'm showing here to the left, if the mortality for one episode of DKA is very minimal, but those who have 2 to 5, you increase mortality, and those who have more than 5 admissions, the rate of mortality increased by 5 to 6-fold. So we have to be careful and talk to this patient and try to help them to prevent readmissions. And we'll talk to you in a minute about what can we do to prevent hospitalization for diabetic ketoacidosis. And finally, in the epidemiology section, we discussed about the difference between outcome and mortality of those patients admitted with pure DKA, those patients admitted with HHS, and the combinations. DKA, HHS combined or mixed is associated with a significant mortality compared to those with DKA or HHS alone. So it is quite important to differentiate those presentations. In the pathogenesis, very little has been shown during the past few years. We know that patients with DKA and HHS, the main reason is an absolute or a relative insulin deficiencies. And those are associated with increased counter-regulatory hormones. So in patients with DKA, for example, the lack of insulin decreased glucose utilization in peripheral tissues. And more important, we need fuels. So we're going to break down fat cells, or what we call lipolysis, that increase liberation or secretion of free fatty acids into the circulation. And these free fatty acids and glycerol coming from fat cells are going to increase gluconeogenesis and increase ketones body formations. And of course, when you accumulate ketones, who are a strong acid, needs to be buffered with bicarbonate. And the increased keto acids are going to result in increased anion gap metabolic acidosis, or what we call these days ketoacidosis. And in patients with HHS, they do have enough insulin to prevent lipolysis, but not enough insulin to increase glucose utilization in peripheral tissues. And this results in hyperglycemia, which followed by dehydration, impaired kidney function, and of course, all the alteration in mental status. The other thing that is quite important that we and others have reported is in the role of inflammation and oxidative stress that is present in everybody who has significant hyperglycemia. So it is so easy to say, oh, this is the pathogenesis of DKA and HHS. But again, 1/3 of patients have a combination of both. And of course, you have to use your clinical criteria. With respect to precipitating causes, depends where you practice. So this is a series that we published now a couple of years ago with different rates in different countries around the world. And you have patients with newly diagnosed diabetes that can go from almost nothing to about 20% in the United States. Infections and insulin omission or poor adherence to therapy is the #1 cause of diabetic ketoacidosis and HHS. And this only can be discovered when you talk to your patients and try to support them to prevent readmissions. So infections, especially pneumonias, urinary tract infections are the most common infections for diabetic foot ulcers, but insulin omission accounts for about 50 to 70% of all the cases of DKA in the United States. So this is something new that we had discussed is about diagnosis and laboratory presentations. So here to the left are the clinical presentation of diabetic ketoacidosis, and to the right, the major clinical characteristic of patients with HHS or hyperglycemic hyperosmolar state. DKA developed in hours. Over just a few hours, you stop taking your insulin today, in 2 days, a type 1 will go in ketoacidosis. HHS is usually older adults who have been poorly controlled, who has an infection, but develops over the matter of several hours to days. Most people with DKA are alert. Instead, most patients with HHS have decreased cognitive state. Both present with polyuria, polydipsia, and weight loss that are the result of hyperglycemia for several days. Important is that diabetic ketoacidosis, 60% of patients have nausea, vomiting, abdominal pain. But interesting, hyperglycemic hyperosmolar states usually do not present with abdominal pain, nausea, or vomiting. What that is important is that if you see a patient with DKA that present with those symptoms, you treat them and they usually go away. But if I have a patient with severe hyperglycemia and the patient presents with nausea, vomiting, abdominal pain, and it's not acidotic, I'm going to work him or her up rapidly because I want to discover if there is something that is precipitating the hyperglycemic crisis. In DKA, those symptoms goes away by themselves. Again, 1/3 of patients have a combination of DKA and HHS, so the clinical presentation may vary from patient to patient. So the update, all of these organizations agree on changing the definition of hyperglycemia. And now we consider DKA a glucose greater than 200 or a prior history of diabetes. So if you have diabetes or type 1 diabetes and your glucose is 120 and you have metabolic acidosis and ketosis, you have DKA. And we didn't consider that in previous guidelines. Ketosis, we changed and we're pushing for do more beta-hydroxybutyrate measurement. A level more than 3 is diagnosis of DKA, or you can still use the urine ketone using strip for acetoacetate having 2+ or greater. And we didn't change metabolic acidosis with a pH less than 7.3 or bicarbonate concentration less than 18. So what is new in DKA definition? Well, we used to say 250, now we cut it down to 200. And the reason is that 10% or 14% in some countries of patients with DKA have a glucose less than 200. And as I mentioned before, we added a prior history of diabetes, irrespective of glucose levels. Both of these changes recognize this euglycemic or eunormoglycemic DKA. What about ketones? Again, as I mentioned before, we want the beta-hydroxybutyrate more than 3. We understand there are many countries, unfortunately the United States, one of them, that we still use urine ketone strips in many hospitals. But we are strongly recommended the measure of beta-hydroxybutyrate because it's the main ketones in patients with diabetic ketoacidosis. More importantly, beta-hydroxybutyrate can determine the severity of acidosis and resolution. If you use urine acetoacetate, they usually do not correlate with changes in acid-base disorders. And 50% of patients that you treat and the patient is normal pH goes more than 7.3, you still have acetoacetate in the urine. So it doesn't really help you in assessing resolution of DKA. And there's many drug interference that we have in the manuscript of urine ketones measurement. What about acidosis? We didn't change that, and we still believe that 7.3 and bicarbonate less than 18 are the key criteria. In some areas, such as in the UK, they still use 15, now they're going to go to 18, because most patients come with mild to moderate diabetic ketoacidosis. And very important is that we're going away from Anion Gap. This Anion Gap in the previous guidelines in 2009 was one of the criteria, more than 14, we said. Now we no longer include that in the definition because we know that 1/3 of patients with diabetic ketoacidosis have mixed acid-base disorders, likely due to dehydration, nausea, or vomiting for several days or hours. So the other thing is during treatment, patients come with a large or increased anion gap, but during treatment, they go from high anion gap to normal anion gap metabolic acidosis. So anion gap still okay if you don't have other measurements but measuring beta-hydroxybutyrate or acid-base disorders. But we believe that it has less clinical criteria for diagnosis and for resolution of DKA. We also talk about that DKA severity. And this is going to help us to determine where the patient needs to be admitted. With respect to hyperglycemia, it doesn't matter. It doesn't change if you're mild to moderate or severe DKA. So the average blood glucose in a patient with DKA is about 580 milligrams. Ketones is very important, and we are going to suggest less than 3 or 3 to 6 or more than 6 for severe diabetic ketoacidosis that correlates with the severity of acid-base disorders determined by pH or bicarbonate. Mild DKA have a pH between 7.5 and 7.3, moderate 7 to 7.25, and severe less than 7. and bicarbonate less than 18, 15, or 10, respectively. Something extremely important that correlates with outcome is the level of mental status on admission. Mild is patients that are alert. Moderate, they're a little drowsy. That is, the patient is in stupor or coma. This is a sick patient who has an increased mortality. Therefore, most of these patients need to be treated in acute areas or in the intensive care unit. And the level of care, if you have mild DKA, in my institution, we'll treat them in the emergency room or in the floor. Those who moderate maybe go to a step down. But if you have a patient with severe DKA, with a beta-hydroxybutyrate more than 6, severe metabolic acidosis with a pH less than 7, bicarbonate less than 10, and the patient have altered mental status, they should go to the unit. But again, location of care is a clinical decision, or access or facilities in each hospital. With respect to HHS, we did not change much the criteria. We have a plasma glucose greater than 600 or 33 millimole. And what we did change is that in 2009, we favor the use of effective serum osmolality, not taking in consideration the urea. That is the traditional way to measure hyperosmolality. In this time, we believe that both are equally effective. And effective osmolality more than 300 or total serum osmolality greater than 320 are characteristic of HHS. And they should have absence of significant ketonemia and metabolic acidosis. So the beta-hydroxybutyrate should be less than 3. And pH should be greater than 7.3 and bicarbonate more than 15. But again, there is overlap, and this is emphasized more and more during the last few decades. 1/3 of patients have a combination of these HHS DKA, so you have to use clinical criteria. With respect to management, we have made some changes. First, in the previous guidelines, most of you will remember that there was a 4-bar that was bicarbonate. So we don't believe bicarbonate should be used much unless the patient has significant acidosis. And what we have is 3 important columns. To the left is intravenous fluid, insulin therapy, and to the right, potassium administrations. With respect to intravenous fluids, the fluid of choice has been normal saline, the isotonic 0.9% sodium chloride solution. And it's effective, has been used, it's cheap. But during the last few years, there have been several publications that a balanced crystalloid solution, such as ringer lactate, results in faster DKA resolution, shorter hospital length of stay, and frequent development of hyperchloremic metabolic acidosis during treatment. So in previous guidelines, we only recommended normal saline. Now you have the chance to treat with normal saline or with balanced crystalloid solutions that are both highly effective. And you should assess the level of dehydrations. And you're going to give somewhere around 0.5 to 1 liter per hour for the first 2 hours. And then you're going to try to replace fluid deficits in the following 24 to 48 hours. You should be careful that there are several patients like fluid overload could be a problem. For example, the older adults, pregnant individuals, patients with heart or kidney disease, you have to assess the level and how you're going to replace fluid. But in general, you're going to, the deficit is somewhere around 5 to 10 liters that you have to replace during the following 24, 48 hours. With respect to insulin, we emphasize that not everybody needs to be treated with continuous IV insulin. Patients with mild DKA, they're non-complicated, they can also be treated with sub-Q insulin. This is a global guideline, and there are many countries such as Africa, India, that people treat with sub-Q insulin. Endocrinology, myself, we treat mild DKA over the phone with patients, and we treat them in the emergency room. And you can do sub-Q insulin every 1 or 2 hours. Now, most patients are treated with IV insulin infusion, and this is correct. This is the most effective way, but needs to be hospitalized. And what we start is at 0.1 units per kilo, And we continue until the glucose drop about 250. At that time, we reduce the dose of insulin infusion and we add dextrose in the solutions. It takes about 4 or 6 hours to resolve the hyperglycemia, but it takes 8 to 12 or 14 hours to resolve the acid-base disorder for the beta-hydroxybutyrate to come down, because you have to stop lipolysis. So we want that as soon as the blood glucose less than 250, to reduce the insulin infusion and give dextrose to prevent hypoglycemia. And potassium is quite important. Most people are admitted with normal or high potassium levels because of the lack of insulin metabolic acidosis. But when you start insulin therapy, when you start fluid, you increase kaliuresis or potassium excretion in the urine, the potassium level is going to decrease between 1 to 2 millimole during the next 48 hours. And we and others have reported that the presence of hypokalemia is associated with increased mortality. So these are the recommendations. If the potassium is less than 3.5, hold on. Don't start insulin. Give 10 to 20 milliequivalents per hour for the next 1, 2, 3, 4 hours. And when you tank them up with potassium, you start insulin because you know that it's going to decrease. So if you have 3.5 and you drop potassium by 1 millimole, 1 milliequivalent, you're going to be in high risk for arrhythmias. And if the potassium is greater than 5 or 5.5, just start insulin. That's going to drop the potassium. And for most patients that are presented with 3.5, and we want to keep the potassium levels between 3.5 to 4.5, 10 to 20 milliequivalents per hour should be enough to prevent hypokalemia. What about resolution of DKA? They are, for DKA, pH more than 7.3 and bicarbonate more than 18. Previous guidelines said 15. Now we want to be sure that there's no coming back to ketoacidosis. And we believe that most people should have a ketone level less than 0.6 millimole. And of course, a glucose that is controlled. For a patient with HHS, we want the osmolality, if you use effective osmolality less than 300 for sure. And hyperglycemia should be corrected to less than 250, and the cognitive state to have improved equal to the urinary output. So these are the new resolution criteria. So we learned about how you treat acute DKA, but a lot of emphasis placed in these new guidelines is the transition of care. So remember that the IV, the insulin half-life is less than 10 minutes. So when you're going to transition a patient from IV to sub-Q, you have to give sub-Q dose 1 or 2 hours before stopping the IV drip. If not, the patient is going to go back into diabetic ketoacidosis or severe hyperglycemia. You have many patients are treated with low-dose basal, so you have to see if the patients, when that's the last dose of basal insulin given. The other thing that we don't have no data on ultra-long new insulin like Degludec, Glargine U300, so we're not recommended those insulin for transition. Just the classic NPH or Glargine or Levemir should be okay because we have good data. The use of clinical judgment is imperative. The doctor have to decide when you transition. I tend to do it when the patient is ready to eat. Before a meal, you give rapid-acting insulin, one before they eat, and you give 2 hours before that the basal insulin infusion, the subcutaneous insulin injection. And we have beautiful tables in these new guidelines. So we want to see, when you start the dose, you see who is the patient in front of you. If the patient is frailty, older age, kidney function is impaired. Is the patient going to eat or not? How much insulin the patient was getting during the infusion? So the best way to transition from IV or frequent sub-Q is to maintain dose is shown in this second table. For newly diagnosed patient, we start on 0.5 to 0.6 units per kilo. So somebody like me, I'll start myself in 40 units. I give 20 units of basal, and 5-6 units before each meal. If I'm going to just to start on basal, I give 0.3 units per kilo. And those patients who are frail, those patients who are older, those patients who have chronic kidney disease, instead of starting 0.5, 0.6 units per kilo, you start by half, and you titrate the dose in the following days. The other thing to me is important is the pre-admission insulin requirement. So you take in consideration how much basal bolus the patient is taking in type 1 diabetes, and that guide you to decide what dose the patient should be. Although I don't agree, the committee suggested that you should also take in consideration the IV insulin requirements to calculate the dose. I believe normal, a patient with type 1 diabetes requires about 0.9 units per kilo. So that's what is your goal is going to be, but you're going to start on lower dose to prevent hypoglycemia. Remember, you have to start subcutaneous insulin 1 or 2 hours. Make sure the patient, if you're going to give NPH, has to be given at least twice a day. If you're going to give basal insulin like Largen, Levemir, you start once a day. Some people start twice a day. I don't agree with that. And you're going to give 50-50 basal and bolus. Or in young people or in patients with type 1, some others recommend only 40% basal, 60% prandial insulin. Extremely important. Do not continue or initiate SGLT2 treatment during hospitalization. Patient with type 1 diabetes is contraindicated the use of SGLT2s because of the risk of ketoacidosis. Now, if the patient have type 2 and develop DKA, can you start SGLT2s? Yes, after a few weeks or month. But make sure the patient doesn't have type 1 diabetes. So the other thing is you have to get the patient ready to be discharged. That's right. You start your bolus, you agree, you change your medications, and make sure that the patient has enough insulin when they go home. So there are some data on using low-dose basal insulin before insulin, during the IV insulin infusion. And this is something that there have been 6 or 7 papers published. And you can start basal insulin during the infusion. I usually start 2 hours before the patient is ready to eat, the patient is ready to stop the insulin infusion. Finally, let me just review very briefly about complications and transition of care. First, hypoglycemia. It's very common. It's reported in 15 to 30% of patients with type 1 diabetes in the hospital. And a low blood glucose less than 40 milligrams is associated with 3 to 5-fold increase in mortality. So, frequent blood glucose monitoring is indicated. When the blood glucose is less than 250 during the IV insulin infusion, make sure you start dextrose and you reduce the dose of insulin. Hypoglycemia is a serious complication in patients with hyperglycemic crisis. We discussed before the hypokalemia. Potassium drop between 1 to 2 millimole. So it's a very common complication. It's seen in about 15 up to 50% of some series. And if you have hypokalemia less than 2.5, the rate of mortality increased 2 to 4-fold. So hypokalemia is a serious complication, and doctors and medical personnel should be aware and start monitoring every 4 hours and make sure you give enough potassium. And the potassium is low on admission, just give potassium before insulin infusion. An area of a lot of controversy is the high risk of thrombosis, the hypercoagulable state, both HHS and DKA. We need more research, but we are recommended that these patients admitted with DKA HHS should be given prophylactic doses of low molecular weight heparin. And if you suspect thrombosis or TBT, maybe anticoagulation. Cerebral edema is a complication mainly seen in pediatric population. It's not very common in adults. And many times it's not clinical knowledge. You have to do some imaging studies. So you just have to monitor mental status. And if you suspect, get a CT or MRI and consult neurology, because both in HHS DKA with cerebral edema, mortality can be as high as 30%. Finally, acute kidney injury. This increase in serum creatinine, decrease in GFR is commonly seen. And in patients with hyperglycemic crisis who present with severe acute kidney injury, mortality increased several fold. So again, we need forced hydration. Make sure you follow renal function daily before the patient go home, before you discharge the patient. I kind of mentioned briefly about recurrence. It can be seen in 10 to 20% of patients that readmitted within 30 days. And mortality is high in patients with recurrent episodes, so prevention of recurrence is quite important. And you have to see the patient hopefully within 2 to 4 weeks. Is not always possible. So they use telemedicine or contact by phone, making sure the patient have enough insulin, the patient know how to check, the patient know how to assess the clinical status. So risk factor for DKA recurrence, kidney disease, comorbidity index, discharge against medical advice that is unfortunately not uncommon in some hospitals, or the use of drug abuse, or social determinant of health. You make sure the patient gets enough education. Education is the way to prevent recurrence. Teach the patient about insulin doses, how to adjust the insulin, how to check for ketones and sick day rules. And continuous glucose monitoring has also been shown to decrease readmission for the hospital. And something that I can't say enough is that make sure the patient have enough insulin supply and durable diabetes equipment to last for several weeks or months until you see the patient back in your office. Finally, we are not going to discuss today because of the lack of time, but this new update takes in consideration the importance of frailty, older adults. These patients are high risk and have higher mortality. Again, SGLT2s, don't use it in type 1 diabetes, please. And in type 2 diabetes who have, kidney disease, cardiovascular disease, and the patient develops DKA, stop it. You may restart later on, but be careful. We have a section end-stage kidney disease. How do you manage them? They are prone to fluid overload. They need less fluid, but insulin is the same. Pregnancy, unfortunately, a significant number of people with pregnancy with type 1 diabetes develop DKA in about 10% of cases, and it's associated with serious maternal and fetal complications. And we didn't talk much about COVID, just the increased frequency. We're following these patients to see what is the long-term need of insulin after a DKA. I really thank you for the opportunity to discuss with you this update on the guidelines. This has been a hard work from the American Diabetes Association in collaboration with the European Association of Study of Diabetes, the Joint British Society for Inpatient Diabetes Care, the American Association of Clinical Endocrinology, and Diabetes Technology Society. So thank you so much. And back to you, Rick.
Thank you, Dr. Umpierrez. We appreciate your perspective on the management of hyperglycemic crises and your update on the guidelines for managing DKA. The lower hyperglycemic cutoff level for detecting DKA and ketone monitoring should help further reduce mortality in these patients. Now we'll hear from Dr. Dennis Begos to discuss the options for point-of-care diagnostic testing for DKA patients. Dennis?
Thanks, Rick, and I'd really like to thank Dr. Umpierrez for an excellent and very thoughtful presentation. Both him and his team put a tremendous amount of work into revising these guidelines, and really we're fortunate to have him present for us today. He's really one of the world's thought leaders in managing diabetes and diabetic guidelines, and again, we're very lucky that he's able to give our webinar today. For my portion of the webinar, I'd like to talk about more specifically point-of-care testing for ketones. And really, the question is, has the time come for point-of-care measurement of ketones? So why all this talk about ketones and why now? And really, as Dr. Umpierrez outlined, new guidelines by the ADA and by other societies really highlight the importance of measuring beta-hydroxybutyrate in management of diabetic ketoacidosis. Right now, the U.S. is really behind the U.K. and Europe and other countries in measuring ketones. And point-of-care technology is now available to measure ketones, although it's not yet available in the United States. Applications for this are pending. And point-of-care technology really allows for a faster diagnosis of DKA, more accurate treatment, and more rapid resolutions of diabetic ketoacidosis. And it's, I believe, going to become the standard of care in managing DKA in the very near future. A recent paper looking at point-of-care testing in general from Norway, there was a quote from it that struck me, and it says that point-of-care testing is the fastest growing segment of laboratory medicine, with a universal trend to move the testing out of the laboratories and into the hospital wards and primary health care. And this is something that we're seeing more and more of, and point-of-care testing is really something that's here to stay and going to continue to grow and become more important and valuable to patient care in the future. Let's talk a little bit about ketones. There are really three types of ketone bodies that are important in humans and specifically in diabetic ketoacidosis. Acetoacetate is the first ketone body that's generated during ketosis, but this is rapidly converted to beta-hydroxybutyrate or BHB, and BHB represents about 80% of ketone bodies in circulation during DKA. Another less important ketone body is acetone, which is generally converted from acetoacetate as well and excreted by the lungs. You can see here the physiology of ketone bodies. Again, acetoacetate is the first one that's made. Some of it gets converted to acetone by decarboxylation. The majority of it gets converted to beta-hydroxybutyrate, which is a pH-dependent reaction. So as patient becomes more acidotic, more of the acetoacetate production gets shunted to making BHB, which again is why BHB is the most important ketone body to measure, and it's the most significant ketone body in patients with DKA. So how do we measure ketones? There's really a few different ways. Probably the most common way is to measure it in urine. And the downside to that is it just measures acetoacetate using something called the nitroprusside method. So it does not measure BHB, and it's a qualitative test, so based on color matching of a dipstick. And we'll talk a little bit more about urine testing later. By far the most clinically relevant and the most accurate way to measure ketones is in the blood, measuring BHB. And you see that little asterisk there. I'll explain that further on the next slide. But most blood tests measure BHB. Acetone can also be measured in the breath, but it's not something that's clinically applicable yet, even though people I know are working on techniques to measure acetone. It's not something that's typically used clinically. As I mentioned before, BHB is generally measured in the blood, but a College of American Pathologists survey, or CAP survey, done as recently as 2020, found that about 1/3 of laboratories in the U.S. Were using the nitroprusside method in blood for ketone measurement, so measuring acetoacetate instead of BHB. By contrast, in the UK, all labs measure BHB, and none of them use the nitroprusside method in blood. And about 75% of hospitals in the UK use point-of-care BHB testing. Some of the drawbacks to measuring ketones in the urine is that, as I had mentioned before, it's subjective, so it's based on color. It's qualitative and not quantitative. It only measures acetoacetate, so we're not really measuring the most important metabolite. The ketone strips can be affected by numerous factors, including humidity, heat, and light. And so it's really only appropriate for screening, not necessarily monitoring treatment of diabetic ketoacidosis. The other thing that happens is it really reflects the historical acetoacetate level, because urine can be sitting in the bladder for several hours before it's checked. And the other issue is that acetoacetate in the urine will actually increase with a patient being treated for DKA, so that acetoacetate levels don't accurately reflect the state of ketosis during treatment of DKA. DKA can also cause dehydration, which makes urine output sometimes very low, and it can be difficult to obtain urine in these patients. And finally, with the rise of the use of SGLT2 inhibitors, ketones are absorbed in the urine in patients on these, and so urine ketone may be negative in a patient who is in DKA. And these are some older papers that basically looked at measuring urine acetoacetate versus BHB and showed basically that BHB testing was more appropriate. This paper is a review from 2013 looking at almost 300 patients in 11 centers, and they evaluated BHB testing in the blood versus urine acetoacetate testing, and they found that the testing blood BHB reduced the frequency of hospitalization, so these were patients who were monitoring their BHB at home. In patients who were admitted to the hospital, they had a quicker recovery time. The cost of treating DKA was lower, and patients were more satisfied with BHB blood testing rather than urine testing. And you can see on the right there just a quote from the paper. There's some evidence to support benefits of BHB testing over urine acetoacetate testing to reduce the frequency of hospitalization, lower healthcare costs, as well as to detect resolution of ketosis in a more timely fashion. There's also evidence supporting greater patient satisfaction with BHB testing when compared with urine testing. Another study done back in 2007, this was a smaller study, but this was a study done in the UK that looked at point-of-care BHB testing versus urine acetoacetate testing. And they were previously using urine testing to guide the treatment of DKA and also to establish that DKA had resolved. And you can see the patients that were monitored using point-of-care BHB testing had resolution of their DKA in almost half the amount of time that the urine acetoacetate testing patients resolved. And let's look at some of the guidelines. I know Dr. Umpierrez talked about the current international guidelines. These are some other guidelines that have been present for some time. The guidelines in the UK, which were first written in 2018, were revised just this year from the Joint British Diabetes Society. In these guidelines, they specifically recommend point-of-care testing, and here's a quote from those guidelines. These guidelines recommend that management be based on point-of-care testing of those admitted with DKA. Blood glucose is routinely checked using point-of-care testing, but portable ketone meters now also allow point-of-care testing of beta-hydroxybutyrate, the main blood ketone. Blood ketone measurement represents best practice in monitoring the response to treatment. And these are just some excerpts from the guidelines. They recommend a BHB level of greater than 3 millimoles per liter for the diagnosis of DKA. They also recommend checking BHB every hour using point-of-care testing devices such as the one you see on the right, and looking for a drop of 0.5 millimoles per liter per hour of BHB in somebody who's being adequately treated for DKA. And they also defined resolution of DKA based on BHB levels of, again, less than 0.6 millimoles per liter. Similar recommendations are seen in the ISPAD guidelines. ISPAD is the International Society of Pediatric and Adolescent Diabetes, and they also advocate for point-of-care testing of BHB. They have the same level of 3 millimoles per liter for diagnosis of DKA. They recommend BHB testing every 2 hours, but also aim for a drop of about 0.5 millimoles per liter per hour in a patient who's being adequately treated. They have the same level for resolution of DKA, and they also recommended home testing after discharge. And again, you can see the quote here on the right. Home measurement of blood BHB concentrations when compared with urine ketone testing decreases diabetes-related hospital visits, both emergency department visits and hospitalizations, by the early identification and treatment of ketosis. And in a different paper by Kilpatrick published last year, basically just highlights the use of point-of-care testing, and he mentioned that the convenience of testing and rapidity of results from a point-of-care testing instrument in a hospital setting are the main reasons for implementing blood ketone measurements in both the ISPAD and UK JBDS guidelines. Let's talk a little bit about a problem that is increasing in frequency, and that's Euglycemic DKA. So as Dr. Umpierrez noted, the threshold for diagnosing DKA in terms of blood glucose has been lowered from 250 to 200, and this is really due to the rise of Euglycemic DKA. And Euglycemic DKA is basically DKA with a normal or only minimally elevated blood glucose. These patients may also not have ketones in their urine, and so therefore measuring BHB in the blood is the key for diagnosing these patients. And we see Euglycemic DKA specifically in patients on SGLT2 inhibitors, which are increasing in frequency in terms of number of prescriptions, but it can also be seen in pregnancy, patients with anorexia or other starvation. It can be seen in alcohol use and in patients with liver disease. And you can see here on the left the list of SGLT2 inhibitors that are commonly in use, and they were initially approved for type 2 diabetics, but now they've also been approved for patients with kidney disease and heart failure, as they've been shown to improve both of those conditions in patients even who are not diabetic. They basically work by blocking the SGLT2 membrane transporter in the mostly in the proximal tubule of the kidneys, so it causes glucose excretion in the urine and also some ketone reabsorption, in addition to other things, but that's basically how they work, and that's why these patients have relatively normal or only minimally elevated blood glucose levels. So point-of-care testing for ketones really has a number of benefits, and they include rapid diagnosis, so they can be used in the emergency department, they can be used in outpatient clinics or walk-in urgent care centers. As I mentioned before, they're really becoming more important in diagnosing DKA, specifically for patients on SGLT2 inhibitors. They allow streamline of care, so patients who are on the floor being treated for DKA are undergoing frequent measurement of glucose, and using the same meter, they can have their ketones checked. Thus, they have quicker results, quicker turnaround time. It's more convenient for the caregivers, and it saves the patient on lab draws and phlebotomy. Having this instantaneous feedback allows for faster treatment and reassurance that treatment is moving in the right direction, or if it's not, the ability to correct the treatment. It measures BHB, which is the preferred analyte, as we discussed, and patient satisfaction is improved using point-of-care testing for ketone measurement. Some of the pitfalls are that interfering agents can cause decrease in accuracy and precision of ketone measurement, and interfering agents are well known in measurement of glucose. And really the same technology that's used for measuring glucose is used in ketone meters. So the same interfering agents can cause problems with ketone measurement. And serious complications have been reported quite recently due to interfering agents with glucose measurement, not so much with ketone measurement. And those include death, permanent neurologic injury, and other permanent disability from abnormal glucose measurement. In fact, there's been 100 deaths reported from abnormal glucose measurement between 1992 and 2009, reported to the FDA. And there's case reports of deaths as recently as 2021. So this is still an ongoing issue with some glucose meters that they are subjected to interfering agents. And you can see on the right some of the common interfering agents, although there are many, many more. So patients with either a low or high hematocrit can have abnormal blood glucose readings and ketone readings as well. Other sugars can interfere with glucose measurement. Oxidizing agents, which are something that are being used more commonly in treating patients, including vitamin C, glutathione, and acetylcysteine, can interfere with glucose and ketone measurement, and various drugs, some of the more commonly used drugs, including dopamine and even acetaminophen, can interfere with point-of-care testing for both glucose and ketones. Nova Biomedical is recognized as a world leader in point-of-care glucose measurement. Our StatStrip glucose meter has no known interferences, and in fact, it's the only blood glucose monitoring system that's approved by the FDA for use in all hospital areas. We do have a StatStrip glucose and ketone meter that's not yet available in the US, but it does measure BHB in whole blood. There's no BHB interferences, and it's a single meter that can measure both glucose and ketones using two different strips. So to conclude, diabetic ketoacidosis is something that's increasing in frequency, especially euglycemic DKA. Beta-hydroxybutyrate is really the test of choice for both diagnosing and monitoring DKA treatment. The US is behind other countries in the world in ketone testing, specifically point-of-care ketone testing. However, that's likely to change, and point-of-care testing for ketones is soon going to be a standard of care in the US as it is in many other countries. And your choice of point-of-care meters is critically important. So it's important both to have accuracy and precision, but also a lack of interfering agents with the meter. So I wanted to thank you for your attention and attending the webinar today. Now I'll turn it back over to Rick.
Okay, thank you, Dennis. Now, before we begin the question and answer session, I want to remind you to submit questions for Dr. Umpierrez and Dr. Begos using the Q&A tab on your screen. Also, as a reminder, your continuing education certificates will be emailed once you complete the post-webinar survey. A link will be sent to you at the conclusion of this session. Now back to Dennis for the question and answer session.
Thanks again, Dr. Umpierrez, for really an excellent and very thoughtful presentation. As Rick said, we have some questions from the audience. The first question is that some DKA guidelines recommend point-of-care testing for ketones. What are your thoughts on using point-of-care testing for the management of DKA?
So in these new guidelines, we forcefully recommend the use of ketone measurement. In the United States, about 50 to 60% of hospitals still use ketones in the urine, the acetoacetate, which is unreliable. So we recommend to use beta-hydroxybutyrate that can be done by point-of-care testing or by the laboratory by enzymatic method. And in the guidelines, we have a large section recognizing that there is no difference in the use of beta-hydroxybutyrate measurement by point-of-care testing, and is highly accurate compared to the laboratory. So in Europe, let's move to the UK. About 70% of patients are using point-of-care testing, doctors in the hospital, for following up patients with DKA. We encourage that hospitals should start using or laboratory measurement or point-of-care testing. Both are highly effective for the diagnosis, following resolution of DKAs, and resolution of the hyperosmolar state.
Thank you. Let me ask you this. Do you think U.S. laboratories measure ketones adequately? There's some evidence from a recent CAP survey that up to 1/3 still measure acetoacetate in blood.
Most hospitals, especially in non-academic settings, the use of acetoacetate is still widely used. In this guideline, in contrast to the previous guidelines in 2009, we emphasize the measurement of beta-hydroxybutyrate for diagnosis and even to prove resolution of DKA. You can do this by point-of-care testing, and you can do it by laboratory methods. In our institution, for example, at Emory, we still use some acetoacetate in some institutions. At Grady Hospital, our community hospital, we only use beta-hydroxybutyrate for the past 20 years. So it doesn't matter what measure you employ to measure ketones. It can be point-of-care testing, it can be by laboratory enzymatic methods. They're both equally effective.
Thank you. Mortality from DKA in the US and developed countries is very low at present. Do we need to do better?
Mortality has decreased from 95 to less than 1%. in most patients with diabetic ketoacidosis, still kind of 1 or 2% in HHS. And this is based on multiple reasons. First, the availability of insulin. Second, most hospitals have protocols. And we emphasize the need to have protocols to treat this hyperglycemic crisis in every hospital, in every emergency room. A protocol that indicates when you start insulin, how much fluid you give, how much potassium, and recognizing the complication during treatment, like hypoglycemia, like resolution of too rapid resolution of hyperosmolality. So I think that the decreased mortality follows the need for the establishment of protocol for treatment of diabetic ketoacidosis and understanding of pathogenesis and pathophysiology, what's going on with these people. So can we do better? Yes. We can prevent hypokalemia. We can prevent hyperglycemia. We can measure better way to assess ketones. We can assess and mortality, and 1 or 2% when you have 185,000 patients with DKA in the United States per year is significant. So can we do better? Of course, we can prevent complications of treatment.
Thank you. Here's another question. Europe and the UK seem to have a better infrastructure for ketone measurement, specifically using point-of-care testing. Why do you think that's the case? Is the regulatory climate in the US partly to blame?
You are correct. In the UK, for example, 75% of hospitals use point-of-care testing. Here in the United States, it's a combination of laboratory methods versus point-of-care testing. In our institution, we use laboratory enzymatic methods, and we get the results in 45 minutes. Can we do better with point-of-care testing? Yes. The answer and the measurement will be almost immediate. And it will be so easy to determine if somebody has diabetic ketoacidosis or not. Why we don't use ketones? Maybe lack of enforcement from guidelines. And this is one of the main reasons why we updated the diabetic ketoacidosis guidelines to be published shortly in the next few months. So I think that laboratories need to take on consideration, hospital needs to assess and incorporate the measurement of beta-hydroxybutyrate or by point-of-care testing or by laboratory enzymatic methods. But it has to be immediately. So there are hospitals that if they want to measure beta-hydroxybutyrate, it's a send-out test. That is ridiculous. That's right when you can get a very quick response if you do point-of-care testing. So if your hospital doesn't have the ability to measure beta-hydroxybutyrate by enzymatic methods right away, I give you the answer in the next 30, 60 minutes. Maybe a good idea should be to implement the use of point-of-care testing, like there is widely used in Europe.
Thank you. Another question is, should patients on SGLT2 inhibitors be self-monitoring ketones in their blood and not in their urine?
That's an interesting question. So first, in patients with type 1 diabetes, my answer will be, please don't use it. We know that 6% of patients develop ketosis and 4 to 6% develop ketoacidosis. And this is in controlled randomized studies. This is why in patients with type 1 diabetes, the FDA never approved the use of SGLT2s. Now, in patients with type 2 diabetes, now the rate of diabetic ketoacidosis is 5 in 1,000 or less. So it's not very common. So we don't routinely use ketones. So in patients with type 2 diabetes, or maybe those who have type 1.5, maybe that is a consideration. But in general, I believe type 1 diabetes don't use SGLT2s. Patients with type 2 use it. But of course, you have to be aware that rare, but it's possible that those patients may develop ketoacidosis. So if somebody is using SGLT2s, is not going to be eating, is following a ketogenic diet. So this would be something that may be of help. But in clinical practice, I think don't use in type 1, be careful in type 2.
Thanks. And this is the last question from the audience. Do you think ketone measurement should be added to continuous glucose monitoring devices? Should this be done for everyone or just select patients with diabetes?
The use of ketone measurement, continuous glucose or continuous ketone measurement is coming, and I'm aware that several companies are working on that and may be of help in patients with type 1 diabetes. So if I have a patient who has recurrent DKA, or anybody who has been admitted with DKA, we know that 20 to 30% are going to be readmitted within the next 30 to 60 days. And if you have both ketones and glucose measurement continuously, well, you can prevent readmissions. Those studies need to be confirmed in real-world and randomized control studies. But I'm hopeful that when we have those devices that can help us to follow patients, we can improve outcome. The average readmission rate is too high, especially in the United States. And we can, with good, measurement of ketones and glucose, we can do a lot of help for those patients. They can recognize if your beta-hydroxybutyrate goes to 1.5, you better do something or start drinking fluids or start taking more insulin because it's preventable. We treat a lot of patients with DKA in the office or mild DKA. So patients can learn how to prevent ketoacidosis. So I think that when available, I think it would be a great addition to our treatment.
Well, thanks again for your thoughtful answers to those questions and for your excellent webinar. Now I'll turn it back over to Rick.
Okay, thank you to our audience for those thought-provoking questions. We'll conclude the webinar at this point, but be sure to join us again and invite your colleagues to attend the next Nova Biomedical educational webinar. You can register at novabiomedical.com/webinars, where you will also find a full catalog of our on-demand webinar offerings. So for Dr. Umpierrez and Dr. Begos, I want to thank you for your interest and attention, and enjoy the rest of your day.